Good morning. Thank you very much for this kind introduction. In these 20 minutes, I will talk on prevention of bile duct injuries, and I will mainly focus on the essentials of safe cholecystectomy. I would like to start my talk with a case presentation. She is a 76-year-old female, and she had undergone laparoscopic cholecystectomy in another center about 20 days ago, and she developed bile drainage from the wound on postoperative day 7, and then referred to our center with sepsis, ARDC, and she was placed on mechanical ventilation. During the course of this patient, there were many problems. Is there a clear indication for cholecystectomy in this patient? Was laparoscopic cholecystectomy technically done properly? Why diagnosis was on postoperative day 7, not earlier? Why she was referred late on day 20 to an experienced center? And why this patient had such a dismal prognosis? Unfortunately, this patient died in our center. Maybe we have some improper management of this patient in the last part of the hospital course also. I mean, there are many problems regarding this patient. So I think this case by itself clearly underlines the importance of bile duct injuries. In Turkey, we did an investigation with the data of Ministry of Health, and we found that annual number of cholecystectomies are around 200,000, huge number. And if we consider that bile duct injury incidence is somewhere between 0.3 and 1.2, the estimated number of bile duct injuries in this country is about 1,500 cases per year, which is huge. And as an information, our population is around 78 million. So it's extremely important number. Let me start with the essentials of safe cholecystectomy. I think we can group the essentials of safe cholecystectomy in 3 parts. One is technical quality of instruments and devices. I would not go in detail on this, but if we don't have enough supplies, if we do not have enough high-quality instruments, I think it's very difficult to achieve good results. The second one is way of achieving pneumoperitoneum, which I will deal later in the coming slide. And I think the most important part is to achieve a critical wave of safety. What's the safest method for trocar insertion to avoid complications? We have 3 methods. Direct insertion, just lift the belly and insert the trocar directly, varus needle method, and open technique. There is no randomized study showing that one of these methods is better than the other, but there are some case studies, and there is a randomized study performed by gynecologists for pelvic surgery, not for laparoscopic surgery. And essentially, the complication rates are similar. So you can do either of them according to your preference. But I would like to underline an important point. In patients with previous laparotomy, especially with midline incision, open technique should be considered. In these patients, direct insertion or varus needle technique may be problematic. Now, I would like to share a video with you. Can you play this video, please? This shows an open technique. We just perform a little incision as usual in laparoscopic cholecystectomy, but we see the peritoneum directly and insert the trocar under direct vision. And with this way, you can prevent the complications just at the beginning of the surgery. Critical wave of safety should be achieved in all the cases of laparoscopic cholecystectomy. If I would like to summarize my talk in one sentence, this sentence will be: critical view of safety should be achieved in all the cases. What's this? What's this concept? First of all, we should start the dissection from the gallbladder infundibulum, not from the tubular structures joining the gallbladder. One may think that it's time-consuming. Why do we start from the infundibulum, not from just on the top of the tubular structures? It may be easier, it may be less time-consuming, but it carries risk of complications. So, first of all, start the dissection not over the tubular structures, from the gallbladder infundibulum. The second important concept is division of both anterior and posterior peritoneum. Posterior peritoneum division may also facilitate to achieve the critical view of safety, and additionally, posterior or lateral, we use this terminology interchangeably, posterior and lateral peritoneal approach, also it's safer. There are no major structures in the posterior, under the posterior peritoneum. And after this mobilization, after this division, 1/3 of the distal gallbladder should be lifted off the liver bed. Distal 1/3 of the gallbladder should be lifted off the liver bed. In other words, mobilization of the distal 1/3 of the gallbladder. And finally, there should be only 2 tubular structures joining the gallbladder. If we see 3 tubular structures, and if we have miserroneously interpreted this as, oh, there may be 2 cystic ducts, then you are in trouble. There is always 1 cystic duct. Very, very rare, there are some gallbladder anomalies, there may be 2 cystic duct, but this is an extremely rare exception. And also 2 very important points. Please do not clip any structure unless it's encircled completely. We should see the end, distal part of the clip before applying, and cautious use of electrocautery. Most of the bowel and duodenum injuries are secondary to inappropriate use of electrocautery. It's very, very important. Now, I would like to show a video, one of our cases. Can we start the video, please? And for electrocautery, the power should be very low, with very low power electrocautery. And as you may see here, we would like to start the dissection from the infundibulum. Cystic duct is probably here, and cystic artery is probably here. I don't start dissection from here, from the infundibulum. And very slowly, very cautiously, we can here find the cystic duct. It looks like a cystic duct. And during this procedure, the image should be in the center. This is wrong. We shouldn't do this. This image should always be in the center. And now we are trying to dissect the cystic duct. And the surgeon may be very happy. Oh, I found the cystic duct. Oh, here is the cystic artery. So he may think that he's done. I finished this case. And now he encircled the cystic duct, and he's ready to clip. My point is, please do not use this approach. This is wrong. This is wrong because we did not achieve the critical view of safety. What needs to be done? This posterior or lateral peritoneum and this anterior peritoneum should be divided before clipping any structures. Which device can we use? Which instruments can be used for division of peritoneum? You can use hook, scissors, whatever. It depends on your preference. There is no difference regarding the complications. The device, the instrument which you are most familiar with is appropriate for this division. Now we'll open up 1/3 of the gallbladder and lift the gallbladder up off the liver bed. Now, we achieved the critical view of safety. We can see the liver behind here, and this is cystic artery. Actually, you can see the posterior branch of cystic artery. This is the main trunk of cystic artery. This is cystic duct. Now we are clear about the anatomy, and we can clip these structures. While doing this technique, some of my residents says that, yes, this is good, but it's time-consuming. Yes, it's time-consuming, but it's safe, and you can prevent most of the biliary injuries with this approach. We can skip the video now. Okay, then we'll clip and continue. Now, Now I would like to share another video with you. This video is a courtesy of my friend, Professor Ahmet Balık. In this surgery, there is a misinterpretation that this structure is cystic duct. The surgeon is dissecting this tubular structure, and he encircled this, and you see he's clipping without achieving critical wave of safety. Now he cut the cystic duct, which he thinks this is cystic duct. Actually, this is common bile duct. Now he continues the dissection. He thinks that this is cystic artery. Maybe he's right. Then he is going on. He is lifting the liver, and with a energy device, he cut some structure here. And look, bile is coming. This is common hepatic duct. And most of the injuries are seen as an error, as a misinterpretation or misidentification of bile ducts. This is the basic mechanism of these injuries. Typically, Strasberg 2 injuries. If the gallbladder has a more traction than the needed, erroneously, one may cut main bile duct with intention of clipping cystic duct. This is the main mechanism of these injuries. Now, I would like to a very short video from one of. Don't start the video. Başlamayın. This is one of my cases that we operated on recently. Look at this gallbladder. This is gallbladder. This is infundibulum, and this looks like long cystic duct. I think everybody may think that this is cystic duct. Video, please. But we achieved a critical wave of safety in this patient. And now when we have exposure of the color triangle, now almost we have encircled this structure. Okay? Almost we have encircled. But here, please look that. This is hepatic duct traveling like this. You see? Very short cystic duct. Almost gallbladder directly joining to bile ducts. If you encircle from somewhere here, you will have a Strasberg type 2 injury. And when you achieve the critical wave of safety, the injury is less likely. We are always saying that please achieve critical wave of safety. It's easy to say achieve critical wave of safety, but can we always achieve critical wave of safety? No. Then we have an important question. What to do if critical wave of safety cannot be achieved? I think we have two scenarios. In the first scenario, the anatomy is normal, but inflammation is severe, like acute cholecystitis or thickening of the gallbladder wall or previous surgeries in the upper quadrant. If inflammation is severe, but anatomy seems normal, in other words, we could identify the anatomy, then we can perform partial cholecystectomy if we are experienced in laparoscopic partial cholecystectomy or open cholecystectomy. Either of them is good. The proponents of partial cholecystectomy claims that if you do open cholecystectomy, again, we'll do partial cholecystectomy if there is a severe inflammation. So why not to do partial cholecystectomy laparoscopically? I think it's true, it's reasonable. But doing partial cholecystectomy laparoscopically requires some more expertise and some more experience. If you feel comfortable, go with partial cholecystectomy. On the other hand, if anatomy is not clear, then one choice, just open the patient and go with open cholecystectomy. And these decision processes mainly depends on the experience of the surgeon and preference of the team. What about intraoperative cholangiography? Selective use of intraoperative cholangiography is not recommended. There are some clear indications to use intraoperative cholangiography, and the main indications are uncertain biliary anatomy. During dissection, during laparoscopic cholecystectomy, if we are not clear, if we are not sure about the biliary anatomy, laparoscopic intraoperative cholangiography may help to identify bile ducts. The second indication is planned bile duct exploration. If you are planning bile duct exploration anyway, before doing this exploration, please perform intraoperative cholangiography. And lastly, if we are suspicious or there is evident bile duct injury, intraoperative cholangiography may help to clearly identify the biliary anatomy. In summary, intraoperative cholangiography should be used selectively, not routinely. Another problem during cholecystectomy is having a bile duct injury. What to do if we have a bile duct injury during laparoscopic cholecystectomy? I will not go in detail, but as a part of my talk, I will show you 2 slides. Actually, we have 4 options in case of bile duct injury. Referral after placing a laparoscopic subhepatic drain, to go with laparoscopic repair, or open the patient, laparotomy and repair, and finally laparotomy, expose the injury clearly identify the anatomy, and then decide what to do. We believe that laparoscopic repair should be performed only for minor leaks, not for major bile duct injuries. And laparotomy and expose the injury clearly is dangerous because the level of injury will be extended. So avoid laparotomy, expose the injury clearly. So essentially we have 2 options, referral or laparotomy and repair. So many authors advocate that repair only in experienced centers. In panic, somebody attempts such repairs, and if they are not experienced, the results are poor. As an example of this patient had undergone laparoscopic cholecystectomy, they had a bile duct injury, complete transection, and they did Roux-en-Y hepaticojejunostomy in that center. And after 3 years, this patient was admitted to our center with recurrent cholangitis, many percutaneous endoscopic procedures. This is the percutaneous transhepatic cholangiography for this patient. You may think that this is left duct, this is right duct. No, this is completely right. This is right anterior, this is right posterior. The injury was so extensive that it's like a class skin tumor. And we took this patient to surgery. The surgery was extremely difficult. Look at these 2 bile ducts. This is left duct, this is right duct. They are separated about 2 centimeters. So, I mean, if you are not experienced, if you do such surgeries, then the postoperative course will be very complicated, and fixing such redos may be extremely difficult. And during my last part of my talk, in last 2 minutes, I will try to find the answer. Is bile duct injury a complication or malpractice? Always it can be regarded as complication, but there are some exceptions. If the indication is not appropriate, it may be an issue for malpractice, lack of informed consent, defects in hospital care documentation, like poorly written surgical notes, negligence of symptoms suggesting biliary injury. If the patient says, I don't feel good on the postoperative 2, no, you'll be fine at home, go home, and the patient will come back 5 days later with sepsis, this may be a topic for malpractice. And finally, if we don't have enough resources, if we are not experienced, if our center is not good enough to handle these patients, and if we are not referring these patients to other centers, again, this may be a subject of a malpractice. And these are my last slides. Maybe you are familiar with this cartoon. She's an old lady. If we turn this picture to right, it's something like this. If we turn some more upside down, she's a beautiful princess. This is the same picture. And when we were talking about bile duct injuries about 10 years ago, we were saying that bile duct injuries are perception errors. But now, in 2017, bile duct injuries are not perception errors. These are errors of not achieving critical wave of safety. If we achieve critical wave of safety, there is no problem like perception errors. And finally, I will present you our paper which was published last year in the coordination of Turkish Society of Hepatopancreatobiliary Surgeons. 17 expert hepatobiliary surgeons came together and we worked for about 1.5 years. And we developed a consensus statement using modified Delphi method, many email communications, workshops, meetings, and finally, we developed this patient prevention and acute meningeal biliary injuries during laparoscopic cholecystectomy expert consensus statement, and this was published last year in Turkish Journal of Surgery. I would like to refer you, especially young surgeons, to this article to get some more information about prevention and management of bile duct injuries. Thank you for your attention.